So good morning, good afternoon, good evening, wherever you're joining us from. So welcome to our webinar today. This is an initiative from the PROS LMIC group and the SN team in terms of providing training or webinars regarding pediatric radiation oncology. And today we've been doing this every 12 weeks. And I think today we have the pleasure of talking about radiotherapy neuroblastoma. I think I will introduce Prof. Beata to introduce our speaker for today. Just a few QA issues. We will address questions at the end, and you can use the Q&A tab to just put your questions. We'll be able to go through. If we're not able to go through all the questions during the session, then we'll be able to reach out to you using the COP office. So welcome, Beata. Thank you.
Yes, thank you. And hello, everybody, dear colleagues. It's a pleasure to have this webinar today on neuroblastoma. And I'm particularly happy that Gerd Janssens from Utrecht agreed to give this educational talk. He is a pediatric radiation oncologist in Utrecht, serving for the children from the Princess Maxima center, very experienced in treating children, and also extremely experienced in abdominal tumors and also neuroblastoma. So he's the co-chair of the RT subcommittee in the CIOPEN neuroblastoma group. So I think he's really the best one to discuss neuroblastoma radiotherapy. And Gerd, we are looking forward to your presentation.
So thank you for the introduction, Professor Timmerman. I will do my best, of course, and to make it myself a little bit more easy, I will focus on abdominal tumors or neuroblastomas located in the upper abdomen, and more particular the neuroblastomas with a high-risk profile. I will share my screen now for that. Can you all see it?
Yeah, yes. It's fine, we see it.
Okay, perfect. So these are the learning objectives. After a short introduction, I will speak about the role of radiotherapy in controlling the local regional disease in neuroblastomas, but I will also stress my ideas or what is known from literature about radiotherapy for distant disease. Then a couple of slides on the late effects of radiotherapy to the upper abdominal region. And then I will finish with a couple of slides on the latest advancements in radiotherapy techniques. So I think because the audience is from over the globe with different experiences, I think it's good to fresh up some things. Probably you know them all, but I think it's good to list them. So as you all know, neuroblastomas arise from the neural crest cells. At presentation, you can have symptoms due to the local mass, but also due to the metastatic sites, like bone pain, raccoon eyes. Some children have fatigue, pallor, weight loss. You can also have paraneoplastic syndromes related to these neuroblastomas, and the risk stratification criteria are in fact age, stage, I will come back on this, biological features, and then based on this you put the child in a low, intermediate or high risk profile and treatment approach. So for the diagnosis, we always perform a CT scan, an MRI scan, an MIBG scan, ideally an iodine 123 MIBG scan is performed. We do a biopsy of the primary tumor, of course, to confirm the histology, but also to do a lot of molecular analysis. You have to take bone marrow biopsies, and in the urine you check the catecholamines. And then, as you all know, the children, they get an intensive treatment, and in general, at least in Europe, in the US, let's say in the western part of the world, after this intensive treatment, the event-free survival is around 50%. And relapse patterns, well, mainly, children will develop bone marrow metastases at the time of relapse, and isolated local-regional failures are in fact rare. So now I come back on the staging. Since 2009, we use the International Neuroblastoma Risk Group Staging System. And this relies on cross-sectional imaging, but also per region we defined defined risk factors. So it's a little bit different for the head and neck region, for the thoracic region, and the abdominal region. And for instance, an IDRF is does the tumor encases the vessels? Is there infiltration of the organs, the surrounding organs? So this is well defined per region, and then based on this, you can make or define your stage. So the majority of the children, of course, we treat are children with metastasis, but you can also have, for instance, high-risk neuroblastomas with a localized disease. Then the molecular markers. This is the list of the key unfavorable molecular markers. The MYC-N amplification is known for a very long time. It's independent of age and stage. And then the others, 11q, 1p deletion, 17q gain. This is not from recent date neither. And then more recently, we are aware of the unfavorable contribution of an ALK mutation. The advantage of an ALK mutation is that they are targetable. So you have lorlatinib, crizotinib, for instance. And of course, this list probably will be expanded in the next coming years. And then, who is in fact eligible for a high-risk neuroblastoma protocol? And you can see that it is different in the COG world compared to the CYOPEN world. Of course, I will not go into details. As I mentioned already, the vast majority of these patients, take for instance CYOPEN here, the vast majority are patients with metastatic disease. Then it doesn't matter at the end if they are older than 12 months, whether they have MYC-N amplification, yes or no. But you can also see that patients with an L2 and MYC-N amplification, for instance, they are also treated in high-risk neuroblastoma protocols. Okay, so this is, in my opinion, the optimal treatment based on what we know. So you start with an induction regimen. This is followed by surgery. After this induction scheme, you continue with, and surgery, you continue with your consolidation approach. So then we give high-dose chemotherapy with autologous stem cell rescue. After the consolidation phase and between the maintenance treatment, radiotherapy is planned, and the maintenance nowadays contains an anti-GD2 immune therapy. So the use of high-dose chemotherapy has been introduced since the late 90s. Good to know. And in the maintenance phase, so the publication of Yu et al. Came out in 2010. So from that moment onwards, we apply immune therapy to complete the treatment. So what we know is that after induction chemotherapy, at the end of induction chemotherapy, about 80% of the patients will have at least a partial remission. And we know that a less favorable response to induction therapy is correlated with an inferior outcome. So that's the reason why new studies try to improve the induction response rates. So here you see the current approach in Europe, so the CYOPEN approach, CYOPEN High Risk 2 study. So in this study, we have 3 randomizations. So we have a randomization for the induction chemotherapy. So we compare the German approach versus the rapid COGEC approach. And as I said, the intention is to obtain a very good response after induction chemotherapy. If patients end up with less than 3 active metastatic sites after induction chemotherapy, then they can continue and they come in the consolidation phase. And then there is a randomization between Bumel, so high dose, or a double transplant or a double high dose Thiotepa followed by Bumel. So patients with an unfavorable response, they continue with 3 courses of Temiri, aiming finally to get a good response and to continue with surgery. And then they continue with high dose Thiotepa followed by Bumel. After consolidation, we have the radiotherapy phase, as I told you already. And in Europe nowadays, we have a randomization for patients with residue at the time of radiotherapy. So the standard dose is 21.6 gray, and in case of residue, the role of radiotherapy is still controversial. We allow patients, or these patients are eligible for randomization, no boost versus a boost of 14.4 gray. And then, of course, you continue with your immune therapy. This is the current American approach. So you recognize again the induction, consolidation, maintenance phase. And I made it a little bit more simplified, but the question here is there an additional role for immune therapy in the induction phase? So there's a randomization with or without dinutuximab in the induction phase. Okay, then I will focus more on the loco-regional disease. So what is in fact the added value of radiotherapy in the context of the whole multi-modality treatment? Well, in fact, we never did a randomized controlled trial comparing radiotherapy versus no radiotherapy in the modern era. There are older data, but you cannot compare it exactly. So we don't know exactly. So, of course, again, it's a biased group, and we expect that if radiotherapy is not given, your local regional failure rate is around 30%, 35%. And with radiotherapy, you end up with a local regional failure rate around 10%. And here I have listed a couple of recent trials. So we have the CUG A3973 trial. So these patients were recruited in the period 2001-2006. And they also looked at patients with a residue and without a residue. You can see if there is no residue and you give 21.6 gray, your local regional failure rate is 8.5%. And if you have a residue, it's almost 20%. Then between 2007 and 2012, patients were treated, at least in the US, in the ANBL 0532 trial. And in this group of patients, 21 gray was given, followed by a boost in case of any residual disease. And you can see for the whole group, the local regional failure is 11%. Those without gross residual disease had a local regional failure rate of 8.5%, and with residue, it was 15%. And in Europe, we also did a similar analysis. In Europe, only 21 gray was given, also when surgeons described residual tumor. And you can see if there's no residual tumor, After 21 gray in Europe, 14% local regional failure rates were observed, whereas with the residue it was 27%. And also recently we did our own analysis here in Utrecht. Patients included, or not, it was not a study, it was a retrospective analysis of patients not included in the prospective study. So we had 77 patients. We gave 21.6 gray elective dose and with the boost dose for patients with the residue. You can see here it's a single center experience. The local regional failure rate is 6% if there is no residue, and with the residue and of course a dose of 36 gray, you end up with 14%. So I show you this data just to give you an impression of what you can expect with the radiotherapy for neuroblastomas. So I think it's clear. In Europe, we give 21.6 gray, and then there is an ongoing study with a boost on a residue, and this is the experimental arm. In the US. It's 21.6 gray in fractions of 1.8 gray as a standard dose now. Concerning the timing, well, radiotherapy is given after recovery from the high-dose chemotherapy and the stem cell rescue. And of course, it's always important to look at the organ toxicity. So this organ toxicity within the radiotherapy field should have resolved. You don't have to start radiotherapy, for instance, when your patient still has an active sinusoidal obstruction syndrome. That's very important. So in general, we recommend for SIOPEN regimens a delay of 60 days at least between the stem cell rescue and the start of radiotherapy to avoid gastrointestinal toxicity, but also to reduce the risk of myelotoxicity. Because we have seen, or at least those who treat a lot of children with neuroblastomas, from time to time, there is a risk of some neuropathy. So ideally, radiotherapy should start between 60 and 90 days following the stem cell rescue. And for the American approach, there the recommendation is to start between day 42 and 80. But these patients, they don't receive the high-dose Bimel. They get a different dose of a different regimen, SEM. So how do you contour your neuroblastoma? Well, first of all, I think it's very important to discuss each case with your surgeon and your radiologist. That's in fact the first step. And then, at least that's how I do it, I always start to delineate the required organs at risk. And it's a long list of organs at risk because we steer on these structures as much as possible based on the well-known constraints from literature. So when the organs at risk are delineated, then I reconstruct or I delineate the gross tumor volume at the time of surgery, or at least at the imaging performed after induction chemotherapy and before surgery. So you can see it here, this is the blue contour. So in the next step, I adjust my GTV for organ shifts to create the GTV. That's the edited GTV. That's how we define it nowadays in our daily practice. Afterwards, we add a margin of 5 millimeters to create a CTV. That's the orange line. And I think it's very important, speaking about this CTV, that you correct for the uninvolved tissues. So normally I take a rim of 2 millimeters into the adjacent organ. So I go back now here. You can see that, for instance, in the spleen, I don't take a margin of 5 millimeters, but I only take 2 millimeters. Because, yeah, there's no reason to, to add such a margin unless the surgeon informs you that there was clear invasion of an organ. From time to time, you can have, for instance, a neuroblastoma that invades the kidney or the pancreas. Then, of course, you have to take adequate margins. But if there's no invasion of an organ, you can limit it to 1-2 millimeters, as I do in daily practice. And then, of course, at the end, you have to see whether the full operative bed is still within your CTV after you have done some adjustments. And then all our patients get a 4D CT scan, and our patients also have clips, surgical clips. So we look at the motion of the surgical clips, and we see, taking into account these clips, which additional margin we have to take to generate our ITV. And then the rest is institution dependent. We here in Utrecht, we add margins of 3 millimeters or 5 millimeters to create or to generate our PTV, a little bit depending on the craniocaudal direction or the length of the target volume. So if it is less than 10 centimeters, we add a margin, a PTV margin of 3 millimeters. If it is more than 10 centimeters, then we add a margin of 5 millimeters. But you have to realize this is all in combination with daily online imaging correction. So image-guided radiotherapy. And then, if patients are candidate for a boost and they are randomized for this high dose, then the protocol, the SIOPEN protocol, states that your GTV can be the same as your CTV. So you don't need a margin for your CTV in the boost phase. Yeah, do we have to boost or not? Well, I think based on what I explained it before, I think you already understand that it is controversial. So in the COG study, the surgeons assessed the extent of resection. They said it's more than 90% resected or less than 90%. And there was, in this analysis, a correlation with local progression. So if the resection was more than 90%, the risk of local progression was 8.5%. And when the surgeon said, my extent of resection is less than 90%, then they observed a recurrence rate of around 20%. But it's also good to realize that in this study, the concordance between the surgeon's assessments of resection extent and central imaging review was low. So in fact, surgeons are not the best positioned experts to estimate the level of resection. Then, in the following study, where a boost was given to the gross residual volume, apparently in this study, it was no longer demonstrated that a boost was able to compensate for the local progression. So since this study, and this is published in 2020, so a boost dose is no longer recommended in the COG protocols. Around the same time, the European data were published, and this is an analysis from the SIOPEN high-risk neuroblastoma 1 study, again here with surgeon-assessed extent of resection. So they said it's complete or it is incomplete, and you can see it here in this figure. If your resection is incomplete, then the 5-year cumulative incidence of local progression was 27%, whereas in the cases where the resection was complete, it was only 14%. So that's, yeah, at least for us in Europe, this was an important message. And in fact, the message here is that with 21 gray, you see a difference in local regional failure. And this is also translated in an inferior event-free survival and overall survival. So taking all this information into account, there was for us a reason to explore the role of a radiotherapy boost in a randomized trial. And that's the reason why we do this in our high-risk 2 study. So what about the radiotherapy for distant metastasis? Well, some background. I think it's important to realize that if your PSYOP score, so the MIBG scan that you perform after induction chemotherapy, is prognostic and correlates with a worse event-free survival and overall survival. So here, for instance, you can see the figure at the left side. These are European data. At the right side, you see American data. If your PSYOP score is above 3, your event-free survival is clearly inferior compared to a more favorable score between 0 and 3. And the same is true for the American data. So, in the meantime, patients with a PSYOP score above 3, nowadays they get a treatment intensification. So this is a consequence. And also in the new American trial, dinutuximab is already added to induction treatment to increase the response rate. So these are direct consequences of these observations. Then the question is, can radiotherapy add something in case of a suboptimal response? Well, if you look back in literature, there are a few retrospective monocentric studies performed and published. And what we know from these studies is that the local control rate of the irradiated residual metastasis is around 80%. But the conclusion from all these studies is that, in fact, whether you irradiate or not on these metastatic sites, there's no benefit in overall survival. And that's also a conclusion from these studies, is that the failures mainly occur at sites of initial involvement, even after early clearance. So also the good and fast responding metastatic sites, yeah, they are in fact at risk for a relapse. At the same time, we have to realize that, it's not difficult to irradiate 3, 4, 5 spots, but if you give 21 gray on several long bones, there's of course a risk of late effects. So we have to take this into account as well. So the current policy across Europe and the CUG trials is that in Europe we do not irradiate active residual metastatic sites. This is the policy of PSYOP, the current policy, but it was also the policy in the past. Whereas in the CUG trials, radiotherapy to active residual metastatic sites post-induction is still recommended. If there are more than 5 sites active after induction chemotherapy, the protocols recommend to repeat imaging just before radiotherapy. And if there are still too many lesions positive, then of course you have to discuss the situation with their study coordination. But in fact, the conclusion is that in the CUG trials, radiotherapy is still given for active metastatic sites. Sorry. And then we give 21.6 gray, the same as the primary tumor site. So in Europe, we are thinking of a randomization, with survival, of course, as primary endpoint. But these discussions are still ongoing, and there's no clear proposal at the moment. Then, late effects of radiotherapy to the upper abdomen. Recently, we published this paper, and this paper nicely summarizes a huge effort that we have done over the past couple of years, together with radiation oncologists and some pediatric oncologists active in SIOP-N and also in the SIOP renal tumor study group. So we performed a systematic review, and after going through all the studies and applying exclusion criteria, we ended up with 55 studies that were included in the analysis. So we look at a lot of endpoints, and we try to find levels of evidence for late effects after abdominal radiotherapy. So in the conclusion, you can see it here. So we have high levels of evidence that radiotherapy, also taking into account multimodality approach, radiotherapy is correlated with metabolic syndrome, with diabetes, with functional asplenia. And there's a moderate level of evidence that radiotherapy to the upper abdominal region is correlated with renal cell carcinomas, colorectal carcinomas, but also with chronic kidney disease and a decreased EGFR ratio. And I know most of you will immediately say, and what about the impact of radiotherapy on the growing vertebrae? Well, you can see, we all know that it has effects, but the level of evidence for that is very limited. It's only a very low level of evidence that radiotherapy is responsible for scoliosis. But this has mainly to do with the quality of the studies that has been done over all the decades. And in the same paper, we also listed a number of items, strategies to reduce the risk of late effects. So, of course, nowadays we recommend 3D and 4D based treatment planning. We recommend the highly conformal target volumes. We propose to use IMAT, and if it is possible, to refer patients for proton therapy. We recommend image-guided radiotherapy in order to reduce your PTV margins. We use organ constraints. We do our best to avoid those inhomogeneities on the vertebrae. As I mentioned already, we have our randomized control trial to see whether a boost is needed in case of a residue. We perform quality assurance, at least for patients participating in studies. In this quality assurance, we look at the volumes, we look at the doses, all done by peers. And of course, we can think of the future as well. There is more than what I just listed here. You can even think of adaptive radiotherapy to further reduce your margins. We can try to reduce the dose, the prescription dose. Instead of 21.6 gray, we can reduce it to 18 or maybe to 15 gray. But this should be done in a randomized control way. We can apply or implement auto-contouring. We can think of biological predictors of radiotherapy response, of predisposition syndromes, maybe predictors to evaluate the need for a radiotherapy dose de-escalation. That's how I see the future. It's not there yet, but maybe in 10 years from now, we will have more information about all that. And then my last topic, it's a little bit overlapping with the things I already said before, but image-guided radiotherapy, in my opinion, if you have access to all these tools, is the standard. And I do realize that there's an increasing number of patients that is treated with proton therapy nowadays. But in general, the vast majority worldwide is still irradiated with photons. And more centers have access to IMRT and image guidance. So here you can see the results of our own cohort. So these are patients all treated with image-guided radiotherapy with a margin of 0.5 centimeters, a CTV margin of 0.5 centimeters, and a boost up to 36 gray when there was a residue larger than 1 cube centimeter. So in fact, this is the same as the current SIOPEN approach, the current SIOPEN high-risk 2 approach. So we have data of 77 patients, and 43 patients had no residue, and 34 patients had a residue larger than 1 cube centimeters. And here at the right side, you see the cumulative incidence of locoregional failure. So without a residue, I mentioned these numbers already before, it's 6%, and with the residue, it's more than a residue more than 1 cube centimeter, it's 14%. And the difference, of course, it can be due to numbers, but the difference was not significant, statistically significant. So this is our in-house priority list and our constraints used when planning a patient with a neuroblastoma, but also a patient with a Wilms tumor, for instance. So for us, the contralateral kidney is also priority 1. The data, at least the D mean below 8 gray, comes from the Pentec data. Priority 2 is the vertebra. And you have to take into account the age of the children. Then you have the constraint for the heart. It's also from a Pentec paper, D mean below 10 gray. Priority 4 is the spleen. Then we have the tail of the pancreas, also a D mean below 10 gray. The endpoint, of course, is diabetes. Then we have the bowel. We try to reduce, in line with another publication of Weil, to below 20 gray. For the liver, it's a Pentec paper. The D mean should be below 10 gray. And for the mammary glands, we try to limit the dose to below 1 gray based on the risk of hypoplasia. This is then mainly in girls, and also for breast cancer. These are older data, but 1 gray comes from the Pentec paper. And here you can see, I think most of you are aware of this publication. If you have to irradiate your vertebrae, then at least the area where the primary ossification centers are located needs to be irradiated. So this is in fact the corpus vertebrae, but also the arches around the spinal canal. So this is the minimum you have to irradiate for target volumes adjacent to the vertebrae. And in this same paper, we developed a kind of flow chart where you have to take into account mainly the age of the children. So the very young children up to 3 years, they are most vulnerable for growth deformations. And here we respect a gradient, a left-right gradient of below 3 gray. So up to 3 gray is accepted. And for the older children, you have gradients mainly the left-right gradient and the anterior-posterior gradient are the most important ones. Up to 5 gray is allowed. So you also have to realize that in addition to the well-known impact of the respiration on the tumor bed or on the macroscopic tumor, that also a drift can occur. So this means that during a fraction, your tail of the pancreas and your spleen, they can move independent of the respiration. So you cannot predict this motion based on a 4D CT scan. That's in fact what you have to realize. And we have done this analysis, and well, the conclusion is in fact that based on a treatment plan, taking into account drift of organs, your final mean dose to an organ can be different. And we mainly looked here at the dose on the pancreas and the spleen. It's published if you want to read it. So this means that ideally, when drift occurs during a treatment session, these patients are candidate for a treatment with an MR-Linac, where you can correct for the motion during the radiotherapy. But I have to confess that until now, we did not treat one case on our MR-Linac because of a list of other reasons. And then, of course, I have to say something about proton therapy as well. So I think this is a nice publication. It's recently published. It's a retrospective analysis from the Swedish group. So they collected a group of patients, 30 patients, treated between 2017 and 2024. And of course, a planned comparison was made. And you can see for different structures and organs that with proton therapy, your dose on these structures is always lower compared to photon therapy. You can see it here for the bowel bag, for the liver, for the kidneys, for the pancreas, for the spleen. And I also added here our constraint, the recommendation based on the Pentec papers. So mainly for the bowel, the liver and the spleen, you can see the differences between photons and protons are larger. But what you also can see is that there are almost no, or an exception, this one for instance, no constraint violations. So this means theoretically, if there is no constraint violation, you do not expect that this difference is translated in a clinical or an expected clinical benefit. For the kidneys and the pancreas, for instance, here again you see that with protons there is a slightly lower dose compared to photons. But at the same time you see that, yeah, if you cannot, and that's also our experience here when we do planned comparisons, if you cannot spare the organ with protons, probably in this posterior abdominal area, you cannot spare them with photons, or with photons, you cannot spare them with protons neither. And that's a little bit what you can see here in these kidneys and pancreas figures. Also good to take into account is that the changing air in the bowels can have a negative impact on the dose distribution in proton therapy, and this is more pronounced in proton therapy compared to photon therapy. But anyway, I think it gives you a nice overview of what you can expect from proton therapy in abdominal neuroblastomas. And I think now I come to my last slide. Yeah, I think I have demonstrated that of course, there is an important role, still an important role of radiotherapy in controlling local regional disease. For distance disease, it's very controversial. We have to explore the role in this domain. I have shared with you, in my opinion, most important information related to the late effects by discussing this systematic review. And I think I have stressed the latest advancements in radiotherapy techniques. So thank you.
Yeah, thank you, Gerd, for this clear and nice overview. I think.
Stop sharing. Wait a second.
Yeah, thank you. So Bilal, will you go through the answers? Typically, we have a lot of answers, and there is a need for discussion. So I hope, Gerd, you are ready for answering questions. Bilal.
Yes, we can begin with the question. We have 20 questions up till now, but we have seen that more questions pop in even towards the end. So maybe we request you to stay like 4 or 5 minutes beyond. But I'll begin from the first question. It's regarding L2 neuroblastoma, if indicated for local radiotherapy, unresectable, stationary suprarenal mass. What dose do you recommend? Is it still 21 gray and 14 fractions?
So if I understand well, in case of a residue, that's it? Is 21.6 gray enough? That's your... yeah. Yeah, we don't know. Yeah, exactly. Personally, I always feel more comfortable, in particular, when there is contrast enhancing residue or when the MIBG scan is still positive. I always feel more comfortable when I give a boost. So, yeah, but yeah, I think probably there is also a volume effect. And we never did an analysis, local control in function of a certain volume. A residue of 1.5 cube centimeter probably doesn't need 36 gray, but from time to time you have such an irresectable mass in the abdomen. Yeah, and if it is active, MIBG positive, etc., yeah, then I am not so comfortable with 21.6 gray, to be honest.
Yeah,
but the analysis is never done.
Gerd, I hope you don't mind if I add. So this typically among us panelists we discuss. So
yeah,
the German group had another study before, and all patients with residual disease would receive 36 gray, which is 21 plus boost, and that is still what we are doing in such a case. And we also do MIBG to see if the residual disease is active, MIBG positive. So, but still, I would say that evidence do not force us to give 36 gray. I think 21.6 gray is still a standard dose. And I think we have to balance, of course, against potential late effects. So the German group would give 36 gray, I guess, as Gerd would be doing, but 21.6 gray would be okay too, from my point of view.
Yeah.
Yeah. So the next one I would say for conditions where unfortunate progressive course with disease progressing after stem cell transplant, do you still offer local radiotherapy?
So, if I understand well, if there is progression after high dose, do you continue with the radiotherapy? Well, no, you have to. Of course, the prognosis is very poor in this case, in these patients. That's what we know. No, you have to continue with systemic therapy first. It has no sense to give radiotherapy unless you consider the case as a palliative case. Then, yeah, but then of course you don't give an elective dose anymore.
Yeah, we do the same in Germany. We typically discuss this case. They look for better effective chemotherapy, But of course, we also look into the question, is it a local progression or is it systemic progression? If it's systemic progression, it makes no sense to focus on local therapy. If it's local progression, and for example, we had a similar case yesterday in our MDT, there was no resection done before, it was unresectable and local progression. So we decided to give local therapy because no effective local therapy was done so far. So I think you really have to discuss the case, the site of progression. Was there any surgery, yes or no, before? And yeah, so it's always, I think, the MDT, GERD, I think it's the same what you feel. We really need interdisciplinary discussion for many of those cases.
Yeah, it is the same here in our hospital. But yeah, if there is progression, yeah, we always try to switch to another line of chemotherapy first, and then we continue with radiotherapy. But maybe it's a little bit different from center to center. But I think that's yeah. Next question, Bilal.
Yeah, so it is about for high risk with initially huge pelvic abdominal mass, post-induction, good response, and went for surgery. Gross total resection after then transplant, coming for post-transplant local treatment, where there is no tumor bed, can be identified on the CT scan, and it is anatomically totally replaced by the abdominal organ. What's your recommendation in contouring? So I think to simplify, the person is asking that what do you do when it is completely resected and at the time of radiation therapy you have a normal organ at the tumor bed? How do you control?
Well, you have to go back to the moment of surgery, yeah? And the imaging at the time of surgery is in fact that's what you need to reconstruct your target volume. So if you don't see any tumor anymore, you still have to give 21.6 gray to the tumor bed. So there's always, at least based on the data that I have shown, so there's always an indication for radiotherapy at the tumor bed, even if there is no macroscopic tumor visible.
Yeah, so typically, I think you can locate some of the contact areas where the tumor was in touch with before surgery, for example, spleen or pancreas, or then typically, I think, GERD, you also focus a lot on the vessels in front of the vertebra. So this kind of central structures typically are at high risk. So I think typically you can find high-risk areas and contact areas when looking at pre-surgery images. And I think those you need to find and define or delineate in your tumor bed.
Yeah. In general, the tumor always sticks to the posterior part of the abdomen. And of course, there can be vessels. And the anterior part in general is free. It's just a pushing border. But the posterior part, you should always take it in your target volume in your edited GTV then. Yeah,
I think one of your slides when you were showing the contouring, when you showed the first image with the pre-surgery GTV overlapping the spleen, and then you mentioned that and showed that the contact area over the surface of the spleen medially towards posterior side, towards the abdominal wall, you had your contour there. So the recording of this session would be available, and I think that picture was very well demonstrating an answer to this particular question. So the next question is regarding the role of radiotherapy when you have residual disease in intermediate risk neuroblastoma.
Yeah. Yeah, well, from time to time you have to irradiate such a patient. And then we give 36 gray. It's because of macroscopic disease. If the surgeon cannot remove it, then you have to irradiate this case.
Okay. So that's a tough situation in many scenarios. So the next question is regarding the the decision where there is no facility for stem cell transplant available for high-risk group.
But coming back on this issue, probably it's not accessible for everyone. We always send our data to Cologne and check in the classifier whether the profile of these patients is favorable or not. Because we know that if it is a favorable profile, that even with some residue, you don't have to be afraid. And if it is unfavorable, then we irradiate. That's an additional tool we combine in decision making. Maybe you can, or maybe you decide different, Beate?
No, I think we do it very, very much the same, Gerd.
Yeah.
So what do you do when the facility for transplant is not available?
Can you, what is not available?
What the transplants, the autologous stem cell transplant, high dose chemotherapy is not available.
Yeah, then you irradiate without transplant. That's, of course, yeah. As I said, nowadays, this is the best approach we have. Induction, high dose, and then immune therapy. But in the past, we also had to deal with these scenarios when there was no immune therapy or was no high dose chemotherapy. Yeah, then you have standard chemotherapy and radiotherapy and surgery, of course.
The next one
Then
is
we can
regarding
discuss the dose of radiotherapy, and in the scenarios where your systemic treatment is suboptimal, then I would say my prescription dose for radiotherapy, is ideally a little bit higher, 36, maybe 40 gray.
So again, the next question is about when you have residual disease. In some studies, I believe for COG, it is the boost did not add much in that experience, but the person asked that is there a role for second look surgery to take out the residual disease?
Well, I don't think we have arguments for that. No, I don't think so. In addition, there's a reason. Quite often there is a reason if the surgeons don't remove it. Quite often they are unable to remove it, even in second look surgery.
Yeah, so we sometimes discuss we have a national neuroblastoma tumor board, so it is discussed if patients should be sent to a reference surgeon, because not all surgeons are the same experience. So there may be some benefit of referring the patient to an expert surgeon for neuroblastoma, and sometimes they do it, but very often, I agree with Gerd, it's still not fully resectable. So you always have to balance if that is of any benefit or if it may just also increase the risk for sequelae, because also surgery has issues like VOD, so vascular issues, for example, and also scoliosis is obviously also coming from surgery. So there is a trade-off, and it's hard to say. So we discuss it sometimes, but I don't think we have a lot of evidence for it.
Okay. So the next one, I'm going to read it because I do not understand some of the acronyms. So in LMIC, bone marrow transplant process, waiting list, and paperwork takes a lot of time, and the cases are referred for radiotherapy without transplant. And after that, they consider also RA maintenance. Is that of any significance to irradiate without PMT? I don't know what is RA maintenance. Yeah, do you understand that question?
Yeah, is RA a drug or?
Retinoic acid.
Yeah, retinoic acid, I think it's.
But no, I missed the question.
So simplifying that again, referred with residual disease without transplant, and retinoic acid maintenance. So is it significant to irradiate without transplant?
So I think the question is if RA maintenance is of benefit after radiotherapy if no stem cell transplantation was done, in order to compensate for not having a stem cell transplant.
Yeah, we don't know. It's not based on randomized trials, but I know it's often given to make cells more mature. Yeah, but I don't know exactly. Yeah.
So the next question is about when the para-aortic nodes come out to be positive on surgical pathology, do you irradiate the whole para-aortic chain?
No. We try to find the positive lymph nodes back on the pre-op imaging, and then we reconstruct it in this way. But we never irradiate the whole para-aortic chain, like in renal tumors, for instance. Yeah. No, there's no standard volume for the para-aortic chain.
Yeah, we do it like that. We don't irradiate the whole para-aortic lymph node chain. Only the ones being positive or enlarged, let's say.
Yeah, that's it. And I know the US trials, they used CTV margins of 1.5 centimeter for decades. Now it's becoming 1 centimeter. So in this context, you already cover more para-aortic volumes. But yeah, as I have demonstrated in our own series, we have used 0.5 centimeter margins. And apparently it had not an impact on local regional failure patterns.
Okay.
But yeah, maybe I'm in a luxury position because I have specialized surgeons and radiologists. So that's maybe not always the case. Yeah.
Yeah, so maybe in challenging situations where you do not have good communication with the surgeon, at least you do not know the exact extent of the node, and that makes it different.
Yeah, but there's no indication, even if you don't have a specialized surgeon for neuroblastomas and a radiologist to irradiate the whole para-aortic area like we do in renal tumors.
Yeah.
That's the message. But maybe 0.5 centimeter is maybe
So Reed, we are already 5 minutes above time. So do you want to continue? We have 26 more questions. The other option could be that we send you the questions and then you can write down the answers and we share it with the attendees.
Yeah, so Gerd, what we typically did, we had a table on the questions, and then you and we would give answers in that table, and that would be distributed to the participants. Then we can kind of follow up on the questions after the meeting, if that is fine for you.
It's fine for me. 36 questions you said.
26 left.
Yeah. No, I think it's better to do it afterwards, for sure.
Okay.
So Bilal, you will send Gerd and me a table with the remaining questions. Is that okay?
Yeah, that's right. That's correct. I'll send you the question and we share it with all our registered participants along with the recording.
Great. So thank you again, Gerd, for this excellent talk. Thanks to all the participants. It's always wonderful to see you in that high number of participation. So we had more than 170 participants, and all the questions, I think, are reflecting the high interest in these fields. So Gerd, thank you again. And I'm looking forward to seeing you to the CYOPEN meeting in Copenhagen next week. And we will continue to discuss on neuroblastoma. And we're also looking forward to send you the answers in the table soon. Bilal, you want to finish?
Yeah, thank you so much, Kit, and thank you, Dr. Beate and Dr. Janet Park, for chairing this activity and arranging all these wonderful lectures, very informative for all the attendees. And thank you, Pauline, for co-hosting this with me. So we conclude the session here, and thank you everyone for making it interactive and enjoyable and useful. Thank you, Keith.
Bye.
Bye.